Swayam Prabha. Digital India. Educated India.
Hello, I am Dr. Rama Devi, Professor and Head, Department of Anatomy from Pondicherry Institute of Medical Sciences. Today, we are discussing on the lungs. No, let me repeat. So, just before we start off with the lecture, let us have a case scenario which over the session we will be able to answer the questions which follows that. Mr. X, 45 years old, is a chronic smoker. Over the last 6 months, he developed severe cough, occasional hemoptysis, tiredness and lost weight significantly. X-ray chest followed by CT scan revealed that he had bronchogenic carcinoma. Biopsy of the regional lymph nodes confirmed the diagnosis. Surgical resection was planned. The questions that we would like to answer are: did his lifestyle habituations contribute to his illness? What could be the possible cause of the cough? How does the biopsy of the lymph node help in diagnosis? Does knowledge of the bronchopulmonary segments help in surgical treatment? The specific learning objectives for this session would be where we would discuss on the gross features of the lungs, talk on the fissures and lobes of the lungs, explain the mediastinal surface and impressions on the lungs, hilum and the root of the lungs, discuss the blood supply and the nerve supply, review the lymphatic drainage, and talk on bronchopulmonary segments and various clinical anatomy pertaining to these topics. So, coming to talk of the gross anatomy, the lung has an apex which is located above, the base of the inferior surface which is below, and there are 3 borders: a sharp anterior border, a rounded posterior border, and a sharp inferior border. The surfaces are the costal and the mediastinal surface. Let us look at the gross features and discuss the apex. The apex is the upper portion of the lungs which is located 3 to 4 centimeters above the first rib and costal cartilage, or 2.5 centimeters above the medial end of the sternoclavicular joint. It is covered by the pleural membrane and reinforced by the suprapleural membrane. The relations of the apex at the anterior, posterior and lateral aspects are similar to similar on both the right side and the left side. So, talking of the anterior relations, we have the subclavian artery which passes upwards and outside, and just below the subclavian artery is the subclavian vein, and with the scalenus anterior muscle close to its insertion between the artery and the vein. The internal thoracic artery is also seen over here, arising from the first part of the subclavian artery. Coming to talk of the posterior relations, medialmost and posteriorly is the sympathetic trunk. The stellate ganglion may be seen alongside. Then there is a posterior intercostal artery, the first one, which passes on to drain into the corresponding brachiocephalic vein. There is a superior intercostal artery arising from the costocervical branch of the subclavian artery, and there is the anterior division of the ventral rami of the first thoracic nerve, that is T1, as it proceeds to join with the ventral rami of C8 to form the lower chord of the brachial plexus, which is then seen on the. So, talking of the posterior relations, on the posteriormost side we have the sympathetic trunk with or without the stellate ganglion. Then there is the first posterior intercostal vein which passes on to drain into the brachiocephalic vein of its own side. There is a superior intercostal artery arising from the costocervical branch of the subclavian artery, and there is the ventral rami of the first thoracic nerve which proceeds further to join with the ventral rami of C8 to form the lower trunk of the brachial plexus. This lower trunk of the brachial plexus is seen on the lateral side along with the scalenus medius muscle. Now, talking of the medial relations, they are slightly different for the right side and on the left side. On the right side, we have the right brachiocephalic vein along with the right phrenic nerve and pericardiaco-phrenic vessels. Following that is the brachiocephalic trunk and then the trachea and the right vagus nerve. Whereas on the left side, we have the left brachiocephalic vein and the left subclavian vein, which replaces the brachiocephalic trunk of the right side, and posterior to that we have the esophagus and the thoracic duct. Now, a stab injury to the neck can also cause an injury to the apex of the lung, leading on to an open pneumothorax. If there is a tumor or growth in the apex of the lung, all the above mentioned structures may be compressed or affected and produce a condition what we call it as a thoracic inlet syndrome. Depending upon the structures that are affected, the patient may have one or many of the following manifestations. There may be edema of the face and a swelling with a dusky color due to the compression of the brachiocephalic trunk and the vessels. The radial artery may be feeble or not palpable if the subclavian vessels are affected. The hemidiaphragm of the concerned side may suffer paralysis if the phrenic nerve is involved. There may sometimes be hoarseness of the voice due to involvement of the recurrent laryngeal nerve. Having looked at the apex, now we look at the base, which is the inferior surface, which is resting below, covered by the pleural membrane and resting over each dome of the diaphragm. And here it is related on the right side to the right lobe of the liver, and on the left side to the left lobe of the liver, to the fundus of the stomach, and to the spleen. Looking at the borders, the anterior border is sharp for both sides, it is more or less straight on the right side, whereas on the left side there is, towards the lower portion, there is a deviation, what is called as a cardiac notch, with a small projection which is called as a lingula. This is a way of identification of the right lung and the left lung by looking for the cardiac notch and the lingula. The posterior border is rounded and rests on the paravertebral gutter and related to the upper 10 thoracic vertebrae. The inferior border is sharp and it encloses the base. Now, the surfaces are two: the costal surface, which is covered by the pleura and separated from the lateral thoracic wall by the endothoracic fascia. It is more or less smooth, but it bears the impressions of the ribs and the costal cartilages and alternating with the elevations of the intercostal spaces. The medial or the mediastinal surface is specific and bears the impressions of very many structures and different on the right side and left side. Now, looking at the mediastinal surface of the right lung, the most prominent thing that we see is the structure which is called as the hilum of the lung. This is a region where various structures enter and leave the root of the lung, and this hilum represents the lateral portion of the root. It is covered by a sleeve of pleura, which at the lower portion forms a bilaminar fold called as a pulmonary ligament. The contents are specific. In the root of the lung, in the hilum, there is the eparterial bronchus, there is the hyparterial bronchus with the pulmonary artery in between and pulmonary veins. The pulmonary ligament consists of loose areolar tissue and it might have a few lymph nodes, bronchial vessels. Just anterior to the hilum of the lung is the region of the cardiac impression, and on the right lung we have the impressions formed by the anterior surface of the right auricle, the anterior and right border of the right atrium, and the anterior part of the right ventricle. Just below the cardiac impression, there is a small impression in front of the pulmonary ligament, which is by the inferior vena cava as it passes on to open into the atrium. Now, at the upper end of the cardiac region, there is a vertical impression, the lower part of which is formed by the superior vena cava and the upper part by the brachiocephalic vein. And posterior to the brachiocephalic vein is the impression formed by the brachiocephalic trunk and at the more towards the apex by the subclavian artery. Now, above the arch of the hilum, there is an impression which is formed by the arch of the azygos vein as it proceeds to open into the superior vena cava. And just above this arch, the central region, there is the impression formed by the trachea and the vagus. Behind the pulmonary ligament, we have the impression created by the esophagus. Now, coming to look at the mediastinal surface of the left lung, we see the rounded region that represents the posterior part or the vertebral part, and the conspicuous region is the hilum of the lung, which consists of the openings of the bronchus, the pulmonary artery and the pulmonary veins. And anterior to the hilum, we have the cardiac impression, which is mainly formed by the anterior surface of the left ventricle and part of the anterior surface of the right ventricle. Just at the upper portion of the cardiac impression, there is a small impression may be seen formed by the pulmonary trunk. Arching over the cardiac impression, arching over the hilum of the lung, we have a curved impression formed by the arch of the aorta, which if you see proceeds vertically down, formed by the descending thoracic aorta. Now, at the upper portion, we have a couple of impressions which seem to be dipping into this curved arch of aorta impression, that is formed by the left common carotid artery and by the left subclavian artery. Posterior to that is an impression formed by the esophagus and thoracic duct. The same esophagus also produces an impression behind the pulmonary ligament at the lower portion of the hilar root. Yet another conspicuous feature is the cardiac notch, the curved cardiac notch, and the projection that we see, that is the lingula of the lung. Now, having seen the relations of the lung at various aspects, we see the fissures and lobes of the lung. The lobes are superior and inferior, separated by an oblique fissure. That is the most commonly seen one, and let me repeat this. Having seen the relations of the lung, we now proceed to look at the fissures and the lobes that are formed. The oblique fissure is a common one found in both the right and the left lung. To talk of the oblique fissure, it starts somewhat above and behind the root of the lung, passes upwards and backwards, and then proceeds along the costal surface, which we are not able to see over here, but we can imagine. So, as it goes along the costal surface, it cuts across the posterior border at the level of T3, T4 spine, and then passes downwards and backwards along the costal surface, meeting the midaxillary line at the 5th intercostal space, proceed further down, comes to the inferior border at the 6th costal cartilage, about 7.5 centimeters from the midline, and then proceeds further forward to meet the hilum of the lung at its anterior and lower end. So, this fissure, oblique fissure, divides the lung into a superior lobe and an inferior lobe. This plane of cleavage also has a functional implication, that is, the superior lobe moves laterally and forwards with the elevation of the ribs during respiration, whereas the inferior lobe passes downwards and backwards due to the piston action of the diaphragm. Now, apart from the oblique fissure, the right lung also has a horizontal fissure which starts from the oblique fissure at the mid-axillary line, that is at the 5th costal cartilage, and proceeds forward to cut at the 6th costal cartilage, thereby dividing the superior lobe into a superior lobe and a middle lobe. Now, looking at the left lung, there is a single oblique fissure which is more vertical when compared to that of the right lung and divides the lobe into a superior and an inferior lobe. Now, to recapitulate the structures at the hilum of the lung, in both the lungs, the anterior to posterior positioning of the structures are the same, with the pulmonary vein, pulmonary artery and the bronchus. Whereas, from superior to inferior, on the right lung, we see eparterial bronchus, pulmonary artery, hyparterial bronchus and pulmonary vein. This is because the principal bronchus divides much early than entering the lung, and thereby we have the two bronchus with the pulmonary artery in between. Whereas, on the left lung, we have the pulmonary artery, principal bronchus and the pulmonary vein. This is a pictorial representation of the various structures seen in the root of the lung. Apart from the major structures that we mentioned, there are also pulmonary plexus, some nerve endings, there are small bronchial vessels, some bronchopulmonary nodes, and the pulmonary ligament has got loose areolar tissue with small vessels and lymph nodes. Coming to talk about the blood supply of the lung. The arteries for the conducting part, on the left side there are two bronchial arteries arising from the branch of the descending thoracic aorta. Whereas, on the right side there is a single bronchial artery which might arise from the descending aorta, or it might be a branch of the third right posterior intercostal artery, or it might be a branch coming from the left bronchial artery. However, the respiratory part of the lung is mainly supplied through the pulmonary artery through various pulmonary capillary plexus. To talk about the venous drainage, the arteries, on having reached the lungs, they divide and form ramifications, they form multiple branches, the main part of which is the tubular or the septal branch. The tubular branch mainly supplies the lung parenchyma through pulmonary plexuses, whereas the septal branch mainly supply the pleura through bronchial capillary plexus. All these plexuses eventually drain into the pulmonary or the bronchial veins. The bronchial veins are of two types, that is superficial and the deep veins. There are two bronchial veins on each side. The right side eventually drains into the azygos vein and the left side drains into the azygos vein, the left side drains into the hemiazygos vein or the left superior intercostal vein. The superficial veins drain into the right heart, that is through the azygos and the hemiazygos system, and the deep veins pass into the left heart. So, lungs are mainly drained by the pulmonary veins, that is the superior and inferior veins, which eventually open into the left atrium. Mind you, the pulmonary veins carry the pure blood. Coming to talk of the nerve supply, the lungs are supplied by the anterior and posterior pulmonary plexus, which is formed mainly of the parasympathetic and sympathetic system. The parasympathetic fibers come in through the vagus, which are motor to the bronchial muscles. So, they produce bronchospasm. They are secretomotor to the mucous glands, and they carry the sensory impulses, such as the stretch and the cough impulses. Sorry, I have to repeat this. They also carry the sensations, the stretch and the cough reflex sets in. The sympathetic fibers mainly come through the T2 to T5 spinal segments, and basically they inhibit the parasympathetic action. They are by and large vasomotor, and they are bronchodilators. Irritation of the nerve endings in the bronchial mucous membrane can initiate a cough reflex, which are carried to the parasympathetic system. Talking about the lymphatic drainage of the lungs, there is the superficial system and the deep system. The superficial system, as the name denotes, lies beneath the pleura, and they mainly drain the extrapulmonary bronchi. The deep ones are basically intrapulmonary in location, draining the bronchial tree, pulmonary vessels and connective tissue septa. Both the superficial and the deep veins then pass on to the bronchopulmonary lymph nodes, which are located at the hilum, and these then continue into the superior and inferior tracheobronchial lymph nodes, which are located at the subcarinal region. Thereafter, they form the right and the left bronchomediastinal trunks. These trunks eventually drain at the base of the neck through the left lymphatic trunk or through the thoracic duct. If the deep lymphatics are blocked, they may communicate through alternate channels with the superficial ones and drain into the hilar lymph nodes. The terminal part of the lymphatics is intercepted by the supraclavicular deep cervical lymph nodes, which act as the sentinel nodes. Now, to talk about the bronchopulmonary segments. They are the functional and surgical subunits of the lungs. This represents an area of the lung which is aerated by a tertiary bronchus and supplied by a branch of the pulmonary artery. The intervening intersegmental areolar septa lodges the tributaries of the pulmonary vein which drain them. By and large, these pulmonary segments are pyramidal in shape, with the apex towards the hilum and base towards the surface. There are 10 segments in the right lung and 8 to 9 segments in the left lung. It is to be noted that these bronchopulmonary segments are independent. Let me repeat. It is to be noted that the bronchopulmonary segments are independent bronchopulmonary units, but they are not individual bronchovascular units. So, to recapitulate, each of these bronchopulmonary segment contains the segmental bronchus, the pulmonary and the bronchial arterial branches, the nerves and the lymphatics which go along with them for each of the regions. So, they are each of them have got their own arterial nerve supply, but the pulmonary vein lies intersegmental. So, this explains how the bronchopulmonary segment is not a completely independent vascular unit. Now, looking at the bronchopulmonary segments of the right side and the left side. With 3 lobes in the right side, the superior lobe has got 3 main segments: apical, posterior and anterior. The middle lobe has got lateral and medial segments, whereas the lower lobe has got superior, anterior basal, posterior basal, medial basal and lateral basal segments. Now, looking at the left lobe, we can see that there may be 8 to 9. Here the upper lobe has got apical and posterior fused together into a single one and an anterior. There are also superior and inferior lingular branches. All these 4 together are located within the upper lobe, and the lower lobe has got superior, anterior basal, lateral basal, posterior basal. Medial basal may not be present very many times. Now, having looked at the anatomy of lungs, let us see some clinical anatomy pertaining to the lungs. Bronchoscopy, as the name implies, is a scope or a bronchoscope which is used to visualize the airways, check for any abnormalities through the same following visualization. It can also be used to remove a foreign body or take a biopsy. It can be used very much as a treatment modality as well as a diagnostic modality. Bronchiectasis is a clinical condition whereby you see that this is the interior of the lung, whereby you see that the lungs, the bronchial tree is very much dilated and has got lot of spaces which over a period of time may get filled with secretions and they very often become the source for infection. So, the patient has got lot of respiratory problems, lot of sputum and mucus while coughing. Tuberculosis is a common condition. The tuberculosis of lung is very often associated with multiple changes in the lung, which starts off, it probably initially starts off as an infection, and if untreated or when it goes on for a long time, it can produce multiple changes in the lung. As is seen over here, it can produce damage to the bronchial tree. The parenchyma may also be affected. There may be various lesions in the form of thickening, in the form of cavities, and they may interfere with the respiratory problem. So, overhealing, all these conditions may bring on to scarring of the lungs, or sometimes what we know as shrinking of the lungs, referred to as fibrosis. Cancer of the lungs can be of different entities, quite common, very often associated with smoking, and it can arise either in the air passage or in the lung tissues, and it can be a primary cancer of the lung, whereby the cancer starts over here in any of the tissues in the lung, or it can be a secondary cancer or what we call as a metastatic cancer, because the cancer elements coming from other tissues may lodge in the lung and produce lesions, what we call it as secondary or metastatic carcinoma. So, the next is emphysema is yet another condition which causes distension distal to the terminal bronchioles. There are associated destructive changes in the walls. It causes lot of respiratory embarrassment for the patient. Postural drainage for lung abscess, bronchiectasis, etc. can be done once there is a thorough knowledge of bronchopulmonary segments. The direction of the lung segment with the tubes or with the bronchi draining it helps to reposition the patient so as to drain the abscess in a natural way. Similarly, a thorough knowledge of bronchopulmonary segment is useful for surgical interventions where we plan for bronchiectasis, lung abscess, benign tumors, where only the concerned bronchial segment or the bronchovascular segment need to be removed. So, these are all the possible interventions, modern interventions due to bronchopulmonary segment knowledge. Thank you. What we see here is the right lung, where you can see the anterior border which is sharp and straight, the posterior border which is rounded, and the inferior border which is again sharp, and this is the apex of the lung. To talk of the relations of the apex of the lung, the subclavian artery passes upwards and laterally, and below that we have the subclavian vein impression coming in with the insertion of the serratus here what we see here is the subclavian artery, impression of that passing upwards and laterally, and below that we have the impression of the subclavian vein, and between the two we see the insertion of the scalenus anterior muscle coming in. The internal thoracic artery also arises from the first part of the subclavian artery, and it is seen over here. Coming to talk of the posterior relations, we have on the whole posteriorly the sympathetic trunk with the stellate ganglion, first posterior thoracic vein, superior intercostal artery seen along with that, and then the first branch the first ventral rami of the 11th, this has to be repeated. Coming to talk of the posterior relations, we have the sympathetic trunk with the stellate ganglion most posteriorly. Adjacent to that, first posterior cervical artery, and then the first anterior division of the 11th, this has to be repeated again. So, on the posterior side we have the relation of whereby we see the sympathetic trunk with the stellate ganglion as the posterior most relation on the medial aspect. This is followed by the first posterior superior intercostal vein, and then more lateral to that we have the anterior division of the first thoracic nerve which goes to join with the anterior division of the 7th or 8th cervical nerve and comes to lie on the lateral aspect as the lower trunk of the brachial plexus. To talk of the on the mediastinal structures, to repeat, to talk on the mediastinal surface of the lung, we have the hilum of the lung, which is actually where many important structures enter or exit the lung. So, we have the eparterial bronchus, the hyparterial bronchus, the pulmonary artery and the pulmonary vein C. Lower down, the pleura forms a bilaminar fold, what we call as the pulmonary ligament, which comes down from the posterior aspect of the hilum deep down, and it contains areolar vessels, areolar tissue and some blood vessels and lymph nodes. To talk of the impressions on the medial surface of the lung, so apart from the hilar shadow, we have the cardiac impression, then we have the impression formed by the inferior vena cava, the impression of the superior vena cava on the lower portion, followed by the brachiocephalic vein, the brachiocephalic trunk forming the next impression, and we have the arch of the azygos vein forming a arch above the hilum of the lung, and here we have the subclavian vessels at the end, and the intervening space there is the esophagus, in the intervening space there is the trachea, and we have the esophagus at the posterior portion, posterior to the pulmonary ligament. To talk about the oblique fissure, it starts above and behind the hilum of the lung, passes posteriorly, cuts across the posterior border at the level of T3, T4 spine, passes downwards and forwards, moves across the costal surface of the lung, and it cuts the midaxillary line at the fifth intercostal space and moves further forward, cutting the inferior border at the sixth costal cartilage, passes upwards and ends at the anterior and lower part of the hilum. Here we see the left lung. Please note that the anterior border of the left lung is curved, forming the cardiac notch, and thereafter it shows a projection which is called as the lingula. Looking at the hilum of the lung, we see a bronchus, the pulmonary artery and the two pulmonary veins, and this is the pulmonary ligament. Let us look at the mediastinal surface of the left lung. This is the posterior vertebral region which lies in the paravertebral gutter, and this is the medial surface which has got impressions of various structures. This is the cardiac impression, and above that we have a faint impression formed by the pulmonary trunk, and this is an arched impression formed by the arch of the aorta passing down as the descending thoracic aorta. Related to the arch, we have two impressions formed by the left common carotid artery and the subclavian vessels. Posterior to that, we have the impression formed by the esophagus and the thoracic duct. And similarly, the esophagus leaves behind an impression on the posterior, on the lower part posterior to the pulmonary ligament. This is the oblique fissure of the lung that you see, which follows more or less the same course like that of the right lung, but is slightly more vertical. Talking about the relations of the at the apex of the lung, from the anterior aspect, we have the subclavian vein